All right, so it is 11. Let's go ahead and get started. My name is Brianna. I am part of the CMREN team. Thank you so much for joining us today in this session of opioid use disorders and pregnancy. If this is your first time joining us this week, you do see a slide on your screen on how to claim CME and CE credits. Like it says, these must be done within 30 days of the event. So please go ahead and take a screenshot of this, take a picture of it, and I will post the email and the numbers in the chat in a little bit. Additionally, to claim your SUD CEUs, we will be sending out certificates after the event. So without further ado, I want to introduce our speaker, Nancy Renn-Bugai. So Nancy obtained her master's in nursing and science with a focus on midwifery from the University of Michigan, and her doctorate in nursing practice from Madonna University. Over the years, she has developed an interest in women who suffer with substance use disorders and childhood trauma. She created, with the help of addiction medicine physician, a multidisciplinary and interprofessional program for pregnant women with opioid use disorders called Great Mom. She is a member of multiple organizations, ACNM, AANP, ASAM, and International Nurses Society on Addiction. So without further ado, thank you so much, Nancy, for presenting today, and I will let you go ahead and share your screen.
So I'm going to talk about opioid use disorders during pregnancy. That is what we care for here at the Great Moms program. We do sometimes see women that have other substance use disorders, such as methamphetamine use. We are open to alcohol use disorders, but have not seen many pregnant women for that. We have seen quite a few for the methamphetamine use, but there's not really anything we can give them to treat, but we can support them and encourage them to abstain from use. So that usually works pretty good. So the Great Moms program is a program that came together about 4 years ago almost. Dr. Kara Poland, she's an internist and addiction medicine physician, came to the maternal fetal medicine department and wanted to start something with pregnant women. And I was currently working at the maternal fetal medicine office and had an interest in substance use disorders also. So we got together and came together to make a multidisciplinary program called Great Moms. We consult with our MFM providers. We work with the people in the community to provide support, social support. I do the prenatal care as a nurse midwife. Dr. Poland does the addiction medicine care. I also am waivered, so in her absence, I'm also able to prescribe buprenorphine. And it's been going on for about 4 years, and actually it works fairly well. These are the things that I want to talk about, and basically the increase in opiate use disorders in pregnancy and in women in general. What we recommend for during pregnancy, labor and delivery, and postpartum, and then how use of opiates has influenced issues with the women's children through neonatal abstinence syndrome, and how we work with the NICU unit and the hospital to make that experience for the women a little bit better than it has been in the past. And then how we recommend that the woman and the infant stay together to increase bonding and actually help with the women's recovery, because when women have a baby that they deliver, they're very motivated to get to work on their addiction. So that's good. So the prevalence of opioid use disorders has increased in every population, but it's also increased in the in women. And there has been an overdose rate from painkillers of women of all ages. The increase has been 5-fold. Commonly, this is due to a lot of issues, sometimes social. Some of our patients have received opioids previously in their life due to surgeries, and they've become dependent on those opioids because of that. And when we talk about neonatal abstinence syndrome, if we can get them stable on buprenorphine or either methadone, it works out a lot better, because then usually they're not seeking out other opioids or other medications like benzodiazepines and those type of things. The group of women that usually, or that we've seen have this issue, are women that are really in that childbearing age, and that's why it becomes really, really important. So 5% to 10% of the pregnancies are facing opioid disorder, and then 8 out of 10 women that try to detox will actually go back to their previous use. So one of the recommendations is that if a woman is on buprenorphine or on methadone, that they stay on that treatment throughout their pregnancy. They do not try to detox. And we do have some women that they want to get off the medications because they're afraid that if they're on these medications that CPS will take their children. But we tell them the best thing to do is treatment for them, be stable, and be a good mom, because the fact that they're in treatment and being a good mom, those two things go together. So usually we will keep them on their current treatment. So I was reading some articles last night, and one of them actually said that 85% of women who try to detox in pregnancy will actually go back to previous use within 30 days. So, we want them to be stable. Their social situations a lot of times are unstable, but if we can get them in treatment and keep them there, things really go really well. At least that's what we found in our program. So when we talk, So I put this in, but pretty much there were some studies done on women that were using opioids, just not in treatment, but just out in general. And they found that there was increase in neurocognitive and motor development delays. And so I think that's what's so important, that we treat these women, because the studies have not really been done in women in treatment. And of the few studies now that we're starting to treat women, have shown that really women in treatment do a lot better than women that are not in treatment. So I always tell my patients, when it comes to anything in obstetrics, that we always want to sort of look at the risk-benefit ratio. So if we're going to give a medication such as, nausea medicine, if it's something that is not really recommended in pregnancy but can be used in pregnancy, we always look at, what's the risk of giving you that medication, what's the risk of not giving you the medication, and then we make our decisions based on that. So when we talk about treatment during pregnancy, and we weigh the risks of not treating is the risk of going back to previous use. And so definitely the risk outweigh the benefits outweigh the risk when it comes to treatment. So what happens when a woman uses medication for opioid use disorders? Well, there's a 70% reduction in overdose deaths, because we know that if they try to detox, they're probably going to go back to their previous use, which can lead to overdose. There's a decreased risk in hepatitis B, hepatitis C, HIV, because now they're not using any needles for their use. They're not participating in risky behavior. So there's less STDs. There's less of any disease that they would pick up if they were not in treatment. And one of the things that we see too, that there's increased risk in engagement for prenatal care. At the Great Moms program, we sort of tie in their treatment with their medication. I mean, their prenatal care with their medications. So when we first see a patient, if they're unstable, we will see them weekly. I will see them weekly for their baby. I'll listen to the baby every time they come in. And we try to get them engaged in that prenatal care. The more they hear the baby, the more they connect with the baby, the more they want to be engaged with that baby and engaged in care. So it works really well. As far as fetal benefits, there's less fluctuations in use. So they're not using buprenorphine one day and then heroin another day, and we try to get them very stable on their dose, so the babies fare a little bit better. One of the things that we worry about is increased fetal demise during pregnancy if a woman is currently using, and so being in treatment helps that. There is some risk of a growth restriction. So if we keep the woman in prenatal care and keep her in treatment, we always do ultrasounds as soon as we can when they find out they're pregnant, and then we follow that up with routine ultrasounds at 28 weeks and 34 weeks, because there is a risk of interuterine growth restriction, and so we monitor that. So as long as they're in prenatal care and treatment, we can monitor that. And then it decreases, prenatal care just in general decreases preterm birth. So we're able to see those patients and keep their pregnancies stable. So in my reading, I found a lot of information on the new focus on women in pregnancy. And in September of 2018, the HRSA office, they began a 2-year-long collaboration to develop a coordination model to use for women that have opiate use disorders. They wanted to really encourage collaboration and to look at the whole picture, and they realized that there's a disproportionate amount of women that are suffering through this opioid use disorder, and they actually found that more than among women there was an increase of more than 471% from 1999 to 2015, compared with men who only had 218% as far as overdose deaths. So they looked at what could we do for these women and what would be best practice. And if you look at this scheme that they put together, it really addresses all the different needs of the patient. And I think that's what's really, really important, because I found the women that I work with have suffered through a lot of trauma. They need the support. They have issues with stigma, which I'll talk about a little bit. And so this is sort of the model that they came up with, HRSA came up with, that you really have to put the woman and the family in the middle. And then one of the most important things is that you build trust with the women. I would say that that's one of the most, that they know you're not judging them. They know that you're with them, you're on their team. But other things that they can other things that you can do is, we work with Arbor Circle and a couple of different places to provide recovery coaches. And the more that you can help that woman and get her into social support is better too. And then, we want to make sure that there's providers out there that can provide care for these women. One of the things I'm working on a grant right now, I'm trying to go into OB offices and encourage OB providers to prescribe to prescribe buprenorphine to their pregnant women. I try to tell them this is like hypertension, and giving hypertension medication like diabetes, giving diabetes medication. Giving Suboxone is treating a brain disease, and we need them to be on board. So we increase the amount of providers that provide buprenorphine to patients. So this is just a little scheme I thought was pretty interesting from HRSA that I wanted to share. So once again, one of the most important things I say is building trust. That is for sure. Our patients come in, they know we are on their side. When they first come in, they think they're going to be judged. We let them know that this is not a place of judgment. This is a place of help. And so they tend to really enjoy coming here. Some of the patients don't want to leave, and we say we're an OB unit. We can't keep you for the next 5 years. We only can keep you a little bit after you deliver your baby. And we want to help the women get support systems, educate them about opiate use disorders, that this is a brain disease. This is, not their fault. This is something that needs medication to be helped. And then, like I said, we get the peer navigators, and then we try to get them involved with other support systems in Grand Rapids. And then we make sure that we're very upfront, and they know exactly, what the plan is for them. So what I talked about that before, and I think probably anybody that's on this webinar knows that we have to get through judgment and stigma. And what the words that we use are very important, and to decreasing the stigma that these women feel. And these are some of the things that you can do. Some of the stigmatizing language. I know that I spoke with one of my friends up in Marquette, and I love her dearly. She's my best friend, and all she could talk about is the addict women and the addicted babies, and I didn't get into it with her, but these are the things that we need to change, because women are afraid to seek care because they're embarrassed. It's hard to have an opiate use disorder when you're not pregnant, but when you're pregnant, they know, because it's true, people look down on them and just say, why don't you just stop this? And so there's a lot of stigma, so they're afraid to come into the system. So a lot of times they won't get any OB care. They're also afraid of losing their baby, because these are the stigmatizing languages that they hear. They're afraid they're going to have their baby taken away. And so really, as a medical community, as just a general, community, we need to let women know that this is a brain disease, and we're not going to judge them. We just need to make sure that we support them in their care. So I'm sure, I don't know how many OBs we have on this call, but this is a great article that was put out by the Society for Maternal Fetal Medicine. I think it's one of the best articles that I've actually read regarding women in pregnancy with opiate use disorders. But they came together in 2018, and they had a 2-day workshop on substance use disorders in pregnancy. And what they wanted to do is look at, number one, their prescribing practices, because like I said, a lot of women that we talk to have had surgeries, and they end up getting dependent on the opiates that they're given, so they wanted to look at that. And so the goals of the workshop were to discuss critical issues that pertain to perinatal substance use disorders with a focus on opiate use disorders, also to draft preliminary recommendations regarding screening, pain management, and MAT, medication for assisted treatment. And then basically, how do we fill in those gaps? So if I think I put this in my reference, so I do believe you could read that article if you haven't read it yet. So this is sort of a repeat, basically that we know that women in pregnancy have, increased in numbers, and we really need to get the OBs on board to try to help with this issue. So one of the things that the recommendations that came from this meeting that they had was that pregnancy is a window of opportunity for treatment of all chronic diseases, and that includes substance use disorders. And also women have insurance during that time. So previous to pregnancy, a lot of women are not insured. So to get them in and to get them the care they needed, that's a great opportune time for the providers to step up to the plate and help these women. And then there was high quality evidence that interventions during this time have the potential to improve maternal health, and basically that reaches out into the future. I mean, if you help a mother, you help a baby. If you help a baby, you help the family. So they said all women need to be offered help during this time. And then the standard of care for women who suffer with opioid use disorders should be offered treatment with buprenorphine or methadone to control their illness. And then I did not see anything in this article regarding postpartum care, but our belief at Great Moms is we need to support these women after birth also. It's been found that women postpartum, there's a high number of them that will overdose and go back to previous use because they're just not supported the way they need to. So right now during COVID, we're keeping our patients for about a year after they have their baby, because that first year is they're so high risk for depression and other issues. So we just keep them. So these are our goals. We want to make sure that we prevent withdrawal, we reduce their cravings, and that that we keep them on a steady pace. Basically, naltrexone is not really used in pregnancy, so methadone and buprenorphine really are the two methods that we use. I just wanted to put this out here. This is another resource through SAMHSA, and these were some of the recommendations in this clinical guide. Basically, like I said, medication-assisted withdrawal is not recommended during pregnancy. It increases risk of miscarriage, and that buprenorphine and methadone are the safest medications that you can use to treat a woman during pregnancy, and that because of the half-life of methadone, we have a lot of women that will call and want to be on methadone. Want to be on buprenorphine and they're on methadone. We cannot convert them from methadone to buprenorphine because the half-life is so long with methadone that they go into too much withdrawal. So basically, if they're methadone, the best thing to do is just keep them on methadone. And if they're interested in converting to buprenorphine after they have the baby, then they can do that. But we do have some cases where women need to go from buprenorphine to methadone because they just, need a higher level of care. And then as far as breastfeeding is concerned, with both methadone and buprenorphine, both methadone and buprenorphine are okay in breastfeeding, and we actually encourage the patients to breastfeed with that while they're on that medication. So basically, how do you make the decision? How do you decide on whether you use buprenorphine or methadone? And I've said some things are the higher level of care. Some women just need a higher level of care. So methadone is a full mu opioid receptor antagonist. So we find that women who maybe use a little bit more of the opioids, larger doses of heroin, are not happy with the buprenorphine, and so methadone works really well with them. But I think the risk and the issues are basically probably more important than the benefits, because there are benefits. Methadone is a great method of care. That's what's been recommended for years upon years. So, but the risks are that women will not be able to get to care because methadone has to be administered. It's not prescribed. It has to be administered through a federally funded program. And in many areas, there are no methadone clinics. I was looking at how many methadone clinics were in Michigan last night, and I had a hard time finding very many. A lot of rehab centers, but not any federal methadone clinics. I don't think there's any in the upper Michigan area, so that's one of my areas of concern, and I'm working with them. So a lot of these women socially have issues, so they don't have regular transportation. The methadone clinics are usually open like from 5 a.m. to 2 p.m. and then they close. And then, of course, there's a risk of prolonged QT syndrome. So buprenorphine, of course, my favorite, because that's what we give. That is the reason I think this is such a great method of treatment for women with opiate use disorders during pregnancy. It's a partial mu receptor agonist, and we can give it in offices. It's prescribed. It's not administered, so we can give them a week at a time. If they're doing well, we can give them 2 weeks, and we can give them up to a month. Most of our patients we see at least every 2 weeks, because just the nature of being pregnant, we see patients pretty much every 4 weeks until 28 weeks, and then we see them every 2 weeks, and then at the end every week. So we see them quite frequently. Providers need to be trained for a waiver, although there's a new recommendation, well, I guess they changed the rules basically through the federal government that actually providers can prescribe buprenorphine to women up to 30 without having to go through the whole training and waiver. That's just something new that I read about yesterday. And all forms are safe in pregnancy. Babies born to moms that were on buprenorphine need less medication after birth, and they have better birth outcomes. And the only risk that I can really come up with is that some women just cannot, go weeks at, like a week at a time on treatment. They need to have that daily responsibility of getting to the methadone clinic and the support that the methadone clinic provides. So for some women, that's a better idea. So as part of this recommendation from the meeting that the OBs had, they said that they really recommended like 2 different models of care. And one is a collaborative care model, which is, the OBs, just sort of, collaborate with the MAT providers, and that there's communication between them, and that women are given the opportunity to counsel with social workers. And so it's more of a coordinated care, I would say. And then the one-stop shop, which is what we are at the Great Moms program. So they get their OB care, they get their medication, they can see a MFM if they need to. We now hired a social worker, so they get everything at one place. And then that's what we found. We found that medication, social treatment, and counseling together is the best way to, handle these women, and the best for them. So in labor and delivery, we want patients to always stay on their dose. We never want anyone in the hospital to take their Suboxone buprenorphine away. They're to be maintained on that. In labor, we encourage an epidural because a lot of other pain options are not available to these women. Nitrous oxide can make them a little bit too woozy, so we don't recommend that. They cannot get Stadol because that will cause them to go into withdrawal. So the best thing for them is get them an epidural. As far as C-sections are required, they give them epidurals or spinals. They do, after the birth, they try to do the multimodal approach to pain, which is Tylenol and Motrin around the clock for the whole entire time that they're in pain. And that the other thing that most OBs and OB nurses and providers don't understand is because they're on buprenorphine, they're going to need one to 1.5 times as much of the opioid, for pain that a normal person would need. So sometimes you have to do PRNs in between regularly scheduled medications for pain. And then, of course, we always try to discharge them with less medications, so they have less medications in their cabinet. Postpartum care, we want to encourage that dyad between the mom and the baby. So right now we are doing a method called Eat, Sleep, Console at Spectrum Health, where we keep the mothers with the baby unless they need medications. They're kept in the same room, so the mom and the baby can be together. And we find that encourages bonding with the baby. And also, if they breastfeed, that helps with the baby's withdrawal after birth. We also try to encourage long-acting contraception, just because another baby probably would cause a little bit more social issues if they continue to have babies. So we want it to be their choice to have a child and be stable when they make that choice. We also educate our families on what's important with the baby, neonatal opioid withdrawal syndrome, and what helps with that, as far as, like I said, skin to skin, swaddling, rocking, and basically not being in a nursery where there's lights and the baby's not being held and cuddled. And then an important thing, and actually required, is you need a safe plan of care for these babies. So what's going to happen if you decide you need to go back to previous use? Do you have a safe person to leave the baby with? What is your plan? Who are you going to call? So that is actually required. So we discussed that with the patients. So what about the baby? Because we got two people here. We got the mother and the baby. And a lot of people want to say that babies are addicted. And that's, what my friend talked about is the addicted babies. Babies are not born addicted. They're born dependent on a medication. So there's a difference. Babies are physiologically dependent. They are not, they don't have the ability to have that disruption in the pleasure reward centers. And they can't get out of their cribs and go looking for someone that can give them opiates. So they rely on us to treat them and to wean them off of the medication that they're dependent on. And once they go through that withdrawal, then they shouldn't have any other issues. So this is just something I put in. NAS increases with maternal opioid use, which makes sense. And so we want to make sure that we get more women treated. I put this in because this is from the state of Michigan on how neonatal abstinence syndrome or NOWS withdrawal. Well, this is neonatal abstinence because this goes through everything. This is cigarettes, SSRIs, all kind of withdrawal. So it's definitely increased over the last 10 years. And we're working to try to change that. I did talk about the fact that there are a lot of issues with different areas of Michigan. And you can see by this picture here that Up in the Upper Peninsula, there is a lot more neonatal abstinence syndrome, and then areas where you would typically find treatment, there's less. So my goal in life is to change that in the state of Michigan. So buprenorphine is not adversely affected or does not adversely affect the babies with NAS as far as the dose is concerned. The normal dose of buprenorphine, I would say, would be 8 to 16 milligrams, but it doesn't matter if they're on 8 or on the 16. It's the more they're on doesn't cause more neonatal abstinence, the less they're on, so there's no correlation. So we give the patients what they need. We don't hold it back because we think the baby will do better. We treat the mother the way that she needs to be treated to keep her opioid use disorder stable. And then basically, like I said, breastfeeding babies who are born to women that are on buprenorphine do really well with breastfeeding, and they actually have a better course after birth as far as withdrawal is concerned. Our Great Moms program, as I said before, we came together because normally we had an issue with women having to go to the OB clinic for their OB care. They'd come to MFM to have their ultrasounds, or the hospital. They'd have to go to their MAT provider. So in 1 week, they might have 4 or 5 different appointments. And many of these women, they don't have the money to make it to that many appointments. So as makes sense, they would show up at their MAT provider because to try to keep from going through withdrawal. And so prenatal care sort of went by the wayside. So coming together and creating a compassionate, comprehensive program for these women was our goal. And now, like I said, I'm trying to get other offices to step up and help too. So basically what we want is we want these women to be well. We want them to be happy. We want mamas and babies to have a good life, and we want to treat them and decrease their illicit substance use, and we want to create a situation where their barriers are sort of cut down, and they feel wanted and they feel engaged in their recovery. That really is the goal of treating women during pregnancy. And one of the things that they said in this meeting was that regardless of anything that ever has happened in the past with these women, they all have a right to help and treatment, adequate pain control, caring conversations and relationship building, appropriate and safe discharge, and feeling of mutual trust and non-judgment. And that's what's going to help change the lives of these babies and families. So basically, like I said, healthy mother, healthy baby, that is really what we're going for. And that is our goal at the Great Moms program. And hopefully we can spread this to the rest of Michigan. So once again, we need people to step up to the plate. We need everybody to come together and realize that treatment during pregnancy is so important for everybody involved. Even for us as a community, this is an important issue, and we need to solve this. And this is a slide that Dr. Poland usually puts at the end of all of her talks. So I usually put that in, and and she always wants to let everybody know that we all know people that have lost family members. She lost her brother. I lost my first husband to addiction, and it's an important situation that we help all women. So the Great Moms program, if anybody's interested, if anybody knows an OB that's interested, I'd be happy to reach out to them. And I guess that's my presentation. I have some references here. There's a lot of information on that. So if there's any questions, they can always call me. I gave my my email and they can reach out to me. So.
Perfect. Well, thank you so much. That was an amazing presentation, and I know I have some questions. We do have some time, so if anyone else has some questions, please go ahead and enter that into the Q&A, and I can go ahead and read that off. But I'll start us off. So you maybe mentioned it, and I apologize if I missed it, but how many people have been in the program so far since you guys started in 2018?
Well, we started out really slow, of course, because nobody knew about us. So there, when we started out, we were only seeing, 2, 3, 4 patients. I think we had 10 yesterday, but I think in total, and the MA that I work with and does all our stats, she would know the best. But there's been about, I would say now we're probably up to close to like 100. There was 85 that was the total at the last time that we did our statistics. So about 85. But once again, we do have the issue that no matter how much we tell people we're here, a lot of people just don't refer to us. So and I know, I mean, we feel like we're, the best place for these women to go because we are totally judgmental and we can offer everything at one place. But some women are not interested in that, and that's fine if they want to stay with their MAT provider. So
is your recruitment process more so referrals?
Yeah.
Is that how you, okay, perfect.
Yeah. A woman can self-refer herself, and we do have patients that are on at least their second baby by now. And they will just refer themselves back to us. As soon as they find out they're pregnant, they'll call us and say, hey, I'm pregnant again. And so they can self-refer. That's fine too.
Okay. So we did get a question. Does your office help with advocating for moms who become involved with CPS following delivery as a result of their OUD?
Yes. Well, the interesting thing is CPS has changed. I'm going to tell you that, at least in Kent County. We've worked really, really hard to talk to CPS about substance use disorders. And if a woman is in treatment, and if she comes into the hospital and she has no unexpected results in her urine and she's been with us, CPS does not even get involved. They just talk to her. They say, I don't think even the social workers refer to CPS or call CPS. If they're stable in their treatment and they've never had any unexpected results, this is a treatment. It'd be like calling CPS on someone who has hypertension and isn't taking their medications, or someone who is diabetic and their sugars are out of control because they're not taking their insulin. So that's the way we're trying to get people to understand this.
Okay. Another question. After getting support for 1 year after baby is delivered, what support is provided with a new baby at home? Do you have a policy improvement suggestions?
Well, we tried to get them involved in, like MIP, the Michigan Infant Health Program. And we do have a program that we're trying to start in. Now that we have a social worker, I think that'll go a little bit more smoothly, in that women after that time can be referred to the family practice office, and they will take over prescribing for that patient. They also are happy to take that baby, and we think that that's the best way, is if they can see the patient, see the baby, and see the mother, and prescribe to the mother and prescribe to the baby. Because you can imagine if they establish a good relationship with that mother, she will be more likely to bring her baby back for care and immunizations and that type of thing. So to transfer someone that can go from baby mama and baby in belly to baby out and caring for the mother and the baby at the same time. So that would be ideal. Right now the issue is there's a lot of our patients come from far away. So they come from Greenville, they come from Ludington, they come from all over because that we're their only option. a lot of times they want to return back to their community and back to their original MAT provider and their pediatrician or general practitioner to take care of their baby. And in that situation, we just make sure they're set up with community health. Yeah.
Perfect. So we did have an attendee post the link to the new prescribing guidelines released yesterday. Have you gotten a chance to look at those, or do you have a comment on any of that?
I just looked at it like literally at 4 o'clock yesterday as I was leaving, because I got the link in my mailbox or my email box. But from what I'm understanding, is they're sort of getting rid of the requirement to go to official waiver training and giving providers the ability to prescribe buprenorphine to 30 patients without that waiver training. I'm not sure how I feel about that, because I think that waiver training is really important. That's my feeling. I learned a lot from that. And as an advanced practitioner, I had to do 24 hours of training. I had an additional 16 hours that I had to do above physicians. And I thought that information was really important to caring for patients, but we'll see how it goes.
Yep. So with obviously it is very, very important. Is this something that you guys plan on standardizing after time to try to roll out into all of Spectrum hospitals?
Yeah, we're working on that right now. I'm working on a toolkit. We have a toolkit already that we've developed from what we've done so far, and it's on the Spectrum Health website. And I think anybody can get in there and look at that toolkit. But being a OB provider myself, we are not addiction providers, and there's a lot of questions that come up when you're an OB provider about like prescribing and what to do. Some of the providers are like, well, if they smoke marijuana or if they come in and they have amphetamines, do we continue their care? Well, of course you do, because we're a harm reduction philosophy. So yes, you continue their care. So I know that goes on sometimes. If women are using other substances, they will, some providers will just withdraw that medication. So I want it to be the toolkit. I want it to be like you said, like algorithm type stuff. If then, and smart phrases that they can use so they address all the issues that they need to address in their charting. So I'm developing that, and anybody who decides to do this, we can then share that toolkit with them.
Perfect. Another question, would you talk about Spectrum's Substance Use Disorder Committee and how OB and Great Moms are all meeting to improve care for families?
Oh yes, absolutely. Yeah, we have a committee that we get together with over once a month, and it's at the hospital, and we have a group of people that come in from different disciplines. So we have, NICU, and we have Arbor Circle, and we have the people in the hospital that can change things and the way policies, and then us together, and we all get together and say, how can we improve the transition from our program into the hospital and make this a smooth transition for the babies. And like I said, one of the things that the NICU department came up with that is improving is that Eat, Sleep, Console. We used to use the Finnegan score. I'm not sure, some people don't even know what that is, but it's where you look at the baby and you see, are they crying? Are they, jittery? Are they whatever? And then whether they need medications. And we're going more to the Eat, Sleep, Console, where is the baby eating? Is the baby sleeping? And if the baby is upset, can you wrap them up tight and put them on your chest and console them? And if that is true, then they probably don't need any medication. So yeah, we work with inpatient and outpatient to try to make the make the transition really smooth between those areas of the hospital.
Perfect. So how do you reach out to expecting moms with SUD/OUD that are reluctant or uninformed to seek help, especially those with cultural and financial barriers?
Well, in the state of Michigan, we deal with pregnant women. So in the state of Michigan, if you're pregnant, you get insurance, period. I mean, that's the way it is, unless you make $100,000 or something, but if you do not have the means to buy insurance, you probably can get Medicaid for your care. And once you get Medicaid for your care, you are able to get OB care. And as far as reaching out, we work with the public health department too. We have a committee that meets once a month with the public health department. Once again, that brings in St. Mary's, Metro, Network 180, a lot of different disciplines, and we get together and we talk about women with substance use disorders and how we can help them. So sometimes the public health department, we hope if they run into patients that are having this issue and are reluctant to seek care, they can sort of say, no, this is where you need to go. They'll help you. They're not going to judge you. So, we'll get you all set to go,
Perfect. So I know that you have a multidisciplinary team with, pulling from several different departments. And I know that you work somewhat with social work. Have you thought about, bringing in a CPS specific person to talk about some of the policies, and because that's forever changing?
Yeah, we do that at that public health department meeting. Usually CPS is in that mix too, and every once in a while we'll, tell them, okay, give us a report. What's changed? What's different? What's going on with CPS right now? And I would say, what I tell my patients, because they're so worried that their babies will be taken away, and what I tell them is CPS is there to protect your baby. You just need to understand that. If your baby is not safe, then they will put your baby in a place that is safe. But if your baby is safe with you because you're in treatment and you're doing well, they're not going to take your baby. Nobody wants to take your baby. They want your baby to stay with you. And that's what CPS has been saying over and over. And, I've been doing this for 40 years. So I know how CPS has changed, believe me. They have really changed. They've changed their approach, and their approach is to help mothers be with their babies, not take babies away.
Right. Yep.
Yeah.
Well, I'm not seeing any more questions. Do you have any final thoughts or tidbits that you would like, everyone to take away from this session?
Well, I guess my only tidbit is women who are pregnant need to have the support of a caring provider and system that will take them and help them get through this difficult time and really help them improve and be supported as mothers, because that's why we called it Great Moms, because every mom is great. We know that as soon as a mother is pregnant, it becomes not about them anymore. It becomes about their baby. And we know they all can be great moms. And so all they need is the support of the providers and the community to lift them up and care for them. So it's just stepping up to the plate and being there for these women.
Perfect. Well, we got one last question.
Okay.
Does cocaine and opioids make oral contraceptive less effective?
No, not as far as I know. Mm-mm. Cocaine is a whole different thing. We could probably do just a short thing on cocaine, because cocaine is a tough one, because I tell women cocaine is so dangerous in pregnancy because of the stimulant use, methamphetamines too, as far as damage to the placenta and the chance of abruption and baby dying and mother dying. That's a tough one, but yeah. But no, we encourage the IUD. I mean, I really encourage the IUD. It's like a set it, forget it. you're good for 6 years or 2 years or 1 year or 3 years, whatever, and you don't have to even think about it. Let's get your life together and get you in treatment and get you going in the right direction.
Yep. So we have one more question.
Okay.
How can we be involved with your organization and the Great Moms community?
Well, I guess I would have to know specifics as far as the Great Moms Committee. The committee that I work with a couple different committees. The one at the Public Health Department. So if they're in the city of Grand Rapids, they can get a hold of Sue Sefton at the Public Health Department. If they want to be involved, we're always happy to have new members of the community come together with us. As far as the hospital specific, I'd probably have to talk to them in what respect they'd like to be part of that.
This is an outpatient provider.
An outpatient provider. So it was Spectrum, yeah?
I don't believe so,
Okay.
but I think that, you guys, Patra, you can go ahead and email Nancy and we can get you guys connected.
Absolutely. Absolutely. I'd love to talk to anybody that has any questions.
Perfect. All right. Well, that is pretty much all the time that we have today. So thank you again, Nancy, for your wonderful presentation. It's been amazing. Thank you to all of our attendees today for coming to this session. As a reminder, please, please, please fill out our feedback survey after the conclusion of this event. So thank you all so much and have a great rest of your day.
All right. Thank you.